Hey everybody, this is Sarah Krager. I am an emergency physician and intensivist at UCLA, and this is ICU EDU. We're going to talk about fluids in sepsis. And you are probably saying to yourself right now, not again. I know we talk about fluids in sepsis a lot, but I think we need to talk about it a lot because fluids in sepsis is high on my list of what I like to call misses that matter. Things that we do in the ED, ICU, or floor that are complicated, that take a lot of thought, that it's important we get them right, and when we get them wrong, can cause significant consequences. So, fluids. I think the pendulum, even in my time in medicine, has really swung on this. When I was in med school, I remember people telling me, no, you just give him enough fluids till you have to intubate him, and then that sounds about like the right amount. To now, when sometimes I have residents being like, I'll give maybe a 250 cc bolus and see what happens. And it turns out that fluids are neither great nor evil. It's just that fluids are complicated. And I think the main first thing that we need to do when we're thinking about fluids in sepsis is realize and appreciate the true complexity of this issue. And one of my least favorite things about the Surviving Sepsis campaign is that it simply fails to recognize the degree to which fluids in sepsis are complicated. And it tries to boil it down to a one-size-fits-all magic number of 30 cc's per kilo. And unfortunately, as much as it would be nice to have a magic number, there is nothing magic about 30 cc's per kilo. Now, I think we need to talk a little bit about how we got to those recommendations. And what I don't want to do here is give an exhaustive review of every single study relevant to fluids and sepsis that has ever happened, because that would be boring, and also other people have done that and very well, and you can look up some of the more exhaustive reviews on that. But rather, what I'm trying to do here first is just give you some context for questioning the algorithm that we're being graded on, given to us by Surviving Sepsis. So in order to understand this context, we have to rewind. And we're going to rewind back to the Surviving Sepsis campaign guidelines of 2016. In these guidelines, quote, we recommend that in the resuscitation from sepsis-induced hypoperfusion, at least 30 milliliters per kilo of IV crystalloid be given within the first 3 hours. Now, what's really notable about these recommendations is that they list it as a strong recommendation, but they list the quality of evidence as low. Now, why you would ever issue a strong recommendation with low quality of evidence is beyond me, but that's what they did. And in support of this recommendation, they state the following. Although little literature includes controlled data to support this volume of fluid, recent interventional studies have described this as usual practice in the early stages of resuscitation, and observational evidence supports this practice. So breaking down this statement, I agree with them that little literature includes controlled data to support this volume of fluid. That is absolutely accurate. Then when they point out that recent studies have described this as usual practice, to me that's not terribly convincing. To quote one of my favorite quotes by Bertrand Russell, the fact that an opinion has been widely held is no evidence whatever that it is not utterly absurd. Just because a bunch of people are doing something doesn't mean that we should all start doing that. Finally, they state that there is observational evidence to support this practice. Let me just go through real fast. The observational evidence they cite in these guidelines to support a 30 milliliter per kilo fluid bolus. Study number 1, Levy et al. Intensive Care Medicine in 2010. This study, the main finding of this study, was no association found between a CVP of greater than 8 and mortality. That was the main finding of the study. Study number 2, also by Levy et al. This one came out in Critical Care Medicine in 2015. What they found was that the combined outcome of early fluids and pressors was associated with improved mortality. And I'm like, okay, great. So you give either fluids or pressors to prevent your patient from being hypotensive. Shockingly, that helps. That sounds about right. Okay. The last study on the surface seems much more convincing. This was a study by Leisman et al. In Critical Care Medicine published in 2017. And this study found that early fluids was associated with decreased mortality. But if you read a little bit more into the details of the study, it turned out that 95% of the early fluids group got early antibiotics, and only 65% of the late fluids group got early antibiotics, telling us that, in fact, early antibiotics is helpful. Again, deeply unsurprising, none of these studies, to me, support the idea that 30 cc's per kilo is necessarily a good idea. A study that came out in 2017 as well, that was notably not cited in the guidelines, was Seymour et al. Time to Treatment and Mortality During Mandated Emergency Care for Sepsis. And this study was a huge study. It was done in New York, and it was a multi-center retrospective observational trial of almost 50,000 patients after implementation of a New York State mandate requiring hospitals to follow protocols for early identification and treatment of sepsis. And the bottom line was this. They found that more rapid completion of a 3-hour sepsis bundle and rapid administration of antibiotics, but not rapid administration of fluids, were associated with lower risk-adjusted mortality. And to me, one, it's not surprising that more rapid administration of antibiotics seems to be helpful, but also, more rapid completion of a 3-hour sepsis bundle, that kind of suggests to me that hospitals and emergency departments that are organized, that are well run, that have it together, probably overall give better care for sepsis patients in general. So that was a study from 2017 that was notably not cited. This was another study from 2017. This was Andrews et al. Coming out in JAMA. And this study was the effect of an early resuscitation protocol on in-hospital mortality among adults with sepsis and hypotension. And this actually was a randomized clinical trial. So that's more of the kind of study that we want, prospective randomized clinical trials. And this study included 212 patients with septic shock. And what they found was significantly increased hospital mortality, 48 versus 33%, associated with protocolized fluid resuscitation versus management per treating clinician. All of this eventually culminated in this systematic review article by Pepper et al. That came out in 2018 from the Annals of Internal Medicine. Evidence underpinning the Centers for Medicare and Medicaid Services, Severe Sepsis and Septic Shock Management Bundle, a systematic review. And so this was a systematic review and meta-analysis of all of the data that they could find to date on sepsis-mandated interventions. And with regard to fluid bolus, here's what they found. No high or even moderate level evidence that 30 cc per kilo fluid bolus improved septic mortality. And I'm just going to quote you the conclusion of this paper because it's one of my favorite sentences in a journal article. The Centers for Medicare and Medicaid Services should examine its performance measure approval process to determine how it adopted interventions lacking evidence meeting the agency's own criteria. Tell us what you really think. That is pretty harsh for an article in Annals of Internal Medicine. Now, of course, the Surviving Sepsis campaign to this systemic review and meta-analysis, they wrote a rebuttal. And the rebuttal came out later that year. And this is what their rebuttal stated, and I thought it was really interesting. We were alarmed by Pepper and colleagues' inaccuracies and misrepresentations about the role of SEP1 in CMS quality reporting programs. As long as a hospital reports its data, even if none of its patients with sepsis were treated with SEP1 interventions, that hospital would not be penalized. Interestingly enough, at no point in this entire rebuttal do they try and argue that actually the data was wrong. You misinterpreted, your statistical analysis was wrong. There's data to support doing a 30 cc per kilo bolus. No, they do not make that argument. They make the argument that, no, actually, here's the role of CMS reporting programs, and this is how you're supposed to do it, not actually about the medicine itself. So now let's fast forward back to 2021 and the 2021 Surviving Sepsis guidelines. So these guidelines, very similar to the 2016 guidelines with regard to fluids, state, for sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 milliliters per kilo of IV crystalloid should be given within the first 3 hours. Now, they again state the quality of evidence is low, but this time they switch the recommendation from strong to weak. Now, one of the papers that came out that actually supports this is this paper that came out in Critical Care Medicine in 2019. This was the paper, Evaluation and Predictors of Fluid Resuscitation in Patients with Severe Sepsis and Septic Shock. And what this paper was a single-center, retrospective observational trial of about 1,000 patients with sepsis and septic shock. And they found that failure to reach 30 cc's per kilo by 3 hours was in fact associated with increased hospital mortality, even after controlling for time to antibiotics, disease severity, heart failure, and end-stage renal disease. In contrast to this study, a similar study that came out by Johannes et al., Critical Care Explorations in 2023, had a similar design. It was a retrospective observational trial, but this time it was a multi-center trial and had about 1,500 patients with septic shock and a lactate greater than 4. What they did is they stratified patients by fluid volume given in the first 3 hours. And there was a pretty wide range here. The lowest group was less than 15 cc's per kilo in the first 3 hours, and the highest group was greater than 50 cc's in the first 3 hours. And basically, they found higher mortality in the group that got greater than 50 cc's per kilo in the first 3 hours, fair enough, but otherwise, no differences between the groups in mortality, length of stay, or lactate clearance. And so basically, as long as you didn't get a ridiculous amount of fluids in the first 3 hours, didn't seem to make a difference in this trial, whether you got 10 cc's per kilo, 20, 30, or 40. It didn't really seem to matter. So 30 cc's per kilo wasn't a magic cutoff number in this multi-center retrospective observational trial. Next, we come to the Clovers trial. So this was the trial that came out in 2023, New England Journal, Shapiro et al., looking at early restrictive or liberal fluid management for sepsis-induced hypotension. And what they did in this study, it was one of the first true multi-center randomized controlled trials that we did looking at this issue in the recent past. And they included 1,500 some patients with septic shock. Then those patients, after initial fluid resuscitation, got randomized to either a fluid liberal or fluid restrictive pressor forward strategy after that initial volume resuscitation. And basically, it was an entirely negative study. They found no differences whatsoever at all between the groups in terms of all of the outcomes they looked at. Now, a couple caveats to know about this study. One, the average age of these patients was less than 60 years old, which is a pretty young patient cohort. Caveat 2. They found a non-statistically significant difference, but to me a very clinically significant difference, specific to the subset of patients with end-stage renal disease. In the subset of patients with end-stage renal disease, there was a 27% mortality in the fluid restrictive group and a 47% mortality in the fluid liberal group, with a confidence interval of -41 to +1.5. Now, statistically, this was not a statistically significant difference because they weren't powered to look at this subgroup of patients, but to me, that's a fairly clinically significant difference. But caveat number 3, and I think this is actually the most important one, in this study, they excluded patients if hypotension was suspected to be due to a non-sepsis cause. So they basically had somebody who was pretty at a high level, a critical care fellow, a physician, maybe an ED physician, assess the patient and really think carefully about, do I think their hypotension is due to a non-sepsis cause? How often do we really think that in the rest of the world, you have somebody very carefully thinking about that before giving them additional fluid resuscitation? I mean, hopefully much of the time, but I suspect not all of the time. And the problem with this, and in fact, a problem I think is common to so many of these studies of fluid resuscitation in sepsis, is that we are not very good at diagnosing sepsis. And we're making this assumption when we're looking at these studies of fluids in sepsis, that we can correctly diagnose the cause of the patient's shock to be, in fact, sepsis within 1 to 3 hours of presentation. And what I would actually look at if I were designing these studies was the patients that we actually, in retrospect, did not get diagnosed with septic shock. Because most of these studies are like, okay, we're going to look at the cohort of patients that ended up with a discharge diagnosis of septic shock, but those patients often meet sepsis criteria in the ED because they're so not specific. And so what if we looked at the cohort of patients who got 30 cc's per kilo while in the ED after meeting SIRS criteria, but then were not diagnosed with septic shock? That is the study that I would actually love to do. Because the question is this. We can't conflate these two things. You cannot conflate the question of, is my patient developing shock, with why is my patient developing shock? And a lot of the sepsis criteria that we use to diagnose patients within the first 1 to 3 hours really have nothing to do with sepsis at all. They have a lot more to do with just identifying patients in shock. So these were the most recent sort of big change in how we defined sepsis, because this is all about how we define sepsis. This was the Singer et al. Paper that came out in JAMA in 2016. And these were the third international consensus definitions for sepsis and septic shock, or sepsis 3. And this is what they have to say about SIRS criteria. The current use of 2 or more SIRS criteria to identify sepsis was unanimously considered by the task force to be unhelpful. Yeah, that about sums it up. I think most of us consider SIRS criteria to be completely useless, partially because SIRS can be associated with any kind of shock, any kind of physiologic distress, or not shock at all. In the 2021 guidelines, however, what do they say about this? Well, in the 2021 guidelines, they say the following. We recommend against using QSOFA compared with SIRS, NEWS, or MEWS as a single screening tool for sepsis or septic shock. They don't say we don't recommend doing SIRS, they just say basically that none of these tools are very useful. Because the problem with all these scores, including SIRS, is that they are really good at identifying sick patients, but they have nothing to do with identifying septic patients. And specifically, if you look at SIRS criteria, they really have nothing to do with it at all. This was a paper that came out in 2020, Jensner et al., and it looked at inflammatory response syndrome and associated with increased mortality across the spectrum of shock severity in cardiac intensive care patients. What they found is in their cardiac ICU population, over 1/3 of them met SIRS criteria, and furthermore, positive SIRS criteria was associated with increased mortality. What about leukocytosis? Okay, that's part of the SIRS criteria, and also we feel like somebody coming in with a high white count, that should make us feel pretty good about identifying sepsis as the cause of shock. Turns out not so much. This was a study that came out in WestGym a couple years ago now, and basically it looked at leukocytosis as a predictor of severe injury and blunt trauma. And what they found is that the mean white count was 16.9 in patients with significant blunt traumatic injury, and white count had an AUC of 0.74, predicting serious traumatic injury. If you want a metric for comparison, white count has an AUC of about 0.75 for predicting sepsis. So white count is no more predictive of sepsis than it is of sick patients with blunt trauma. What else are we going to use? If we're saying SIRS is basically useless, we are saying that all these other things, QSOFA, MEWS, NEWS, are good at predicting, sick patients, but not particularly good at predicting septic patients. What do we do? So this is one of my favorite studies to come out within the last year. This was a study from Annals of Emergency Medicine, NAC et al. In 2024. Study was early physician gestalt versus usual screening tools for the prediction of sepsis in critically ill emergency patients. What they did in this study is they looked at the ability of different screening tools to predict sepsis as a hospital discharge diagnosis at 15 and 60 minutes after presentation over about 2,500 patient encounters. And this is relevant. This is the study that I keep saying we should really do this one, because they're looking at hospital discharge diagnosis, but our ability to actually predict sepsis within the time frame that we need to make decisions about fluids. What did they found? Well, they found, in terms of AUC for predicting sepsis as a hospital discharge diagnosis, SIRS, not so good, 0.67. QSOFA, not so good, 0.67. MEWS, not so good, 0.066. But physician gestalt, 0.9. That emergency physician gestalt for predicting sepsis, the hospital discharge diagnosis, at either 15 or 60 minutes, well beat all of the other scores. Now, they also had a machine learning tool in this study, and the AUC of the machine learning algorithm was 0.84. So not as good as physician gestalt, but certainly better than everything else. So I think that's one thing that can be explored in the future if we are looking to scores, but I would say the best available data we have right now is that SIRS, QSOFA, and MEWS are pretty useless for predicting sepsis as an outpatient diagnosis in the first hour of presentation. Physician gestalt is probably good at all that. But given that there is no single test, metric, or score that identifies sepsis definitively, how are we going to make these critical decisions about fluids in the first hour to 3 hours if we can't even accurately define sepsis patients as prescribed to us by the Surviving Sepsis Guidelines? Okay, now let's talk about what I see as possibly one of the biggest problems with the Surviving Sepsis Guidelines, and it is this one. It sounds kind of innocuous at first. For adults suspected of having sepsis, we suggest measuring blood lactate. Now, this is a recommendation that says the quality of evidence is low and the recommendation is weak. Which is all very well and good, but everybody does it all the time anyways. And I actually am not against measuring a lactate in these patients. In fact, I think we probably should be. And I do it all the time, but the catch is you gotta know what to do and not do with that number. The key thing to understand is this. Lactate cannot be used to rule in nor rule out septic shock. And if you only take away 3 pearls from this talk, they are this. 1. Lactate does not equal sepsis. 2. Lactate does not equal sepsis. And 3. Lactate does not equal sepsis. I see so much harm done to these patients when somebody comes in and they seem to meet sepsis criteria and they have a high lactate, so we're like, or just they don't even meet sepsis criteria technically, and they still have a high lactate and we're like, yep, must mean sepsis, better give them some volume. Now, lactate doesn't tell you anything about whether the patient has shock necessarily, and it certainly is not specific to septic shock, right? Having a high lactate tells you nothing about whether or not the patient is actually septic shock. But you can't use lactate to rule out septic shock either. So this was a study that when I first read it, I was like, oh, I'm now deeply concerned. This was a study came out in 2021, Sauer et al. Understanding critically ill sepsis patients with normal serum lactate levels results from a US and European ICU cohorts. So what they did in this study was this. They had a big ICU database. They took the highest lactate in the first 24 hours of admission in critically ill patients with the sepsis who were sick enough to be admitted to the ICU, and they only looked at the patients in the highest quartile of severity of illness score. And they use severity of illness score because it's one of the scores that lactate's not part of the score. And so this is what they found. And keep in mind, these are in patients who are septic, who are sick enough to be admitted to the ICU. 27% of these patients had a lactate greater than 4. 50% of them had a lactate between 2 and 4, and 23% of them had a totally normal lactate, stone cold normal, less than 2. So, yeah, you really can't say, no, they have a normal lactate, I'm not that worried about them. That doesn't work. We've all seen this patient, the little old lady with clear pyelonephritis on labs, on imaging. She looks terrible, she's febrile, she's pretty clearly septic, and her lactate is normal. We have all seen that patient. What do you do with them? And it shouldn't be actually hard now to know what to do with them. Treat them like they're a sick septic shock patient, because they probably are. My feeling about this is, I don't know this for a fact, but what I suspect is part of why you can't use lactate to rule out sepsis like this is because increasingly we're understanding that lactate is not just about hypoperfusion. And probably especially early in the course of shock, lactate is at least as much indicative of a physiologic stress response. And in patients like elderly patients, maybe immunosuppressed chronically ill patients who can't mount a robust stress response, maybe you're just not seeing that lactate until late stages when they actually are hypoperfusing. So is lactate useful? Absolutely. I mean, it's certainly consistent in the literature that a high lactate is a predictor of badness. In any kind of shock, if I see a really high lactate, am I more concerned? 100%. So lactate is useful, just not magic. And in fact, lactate can be dangerous. And lactate is dangerous, I think, in exactly the way that the Surviving Sepsis campaign tries to use it. And so here's my real problem with the lactate recommendation. We suggest guiding resuscitation to decrease serum lactate in patients with elevated lactate levels over not using serum lactate. And my big problem with this is the word guiding, because what on earth does that mean? Lactate is a marker of badness, but extrapolating that to the idea that lactate-guided resuscitation will help patients, that's a whole different question. And what does that even mean? So this was an editorial written by some of the leaders in the field in the Journal of Intensive Care Medicine about lactate and the 10 pitfalls of lactate clearance in sepsis. And I'm just going to quote from this paper because they say it much better than I could. The complexity of lactate makes it impossible to define what goal it should be a marker or target of. Seeking to lower lactate levels by whatever means, given the multiple events that wrecked its blood levels, has no credibility and no logic in terms of hemodynamics, bioenergetics, or tissue protection. Clearly, they have some strong feelings about this. But this is a sort of physiological, philosophical idea that, like, theoretically, it makes no sense to do this with lactate. But actually, how does that pan out if we look at actual patient studies? Because as we all know in medicine, what makes sense physiologically doesn't always make sense practically. So this was a paper that came out in 2024, and it came out in Intensive Care Medicine, and it was a review article that looked at all of the evidence about using serum lactate to guide resuscitation in patients. And to quote the conclusion of this paper, altogether, the current literature on sepsis does not support that guiding treatment based on serial lactate measurements would improve outcomes, and potential harm may result from serial measurements with excessive fluids or excess of vasopressors. And this is getting at what we like to call the lactobolus reflex. I did not coin this term, but I think it's a great one, where you see a lactate and it's high, so you give some fluids. So then you remeasure it as we're supposed to, and it's still high. Didn't come down or even higher. So you give some fluids some more. Then you recheck it and it's still high, so you give more fluids, and that is the lactobolus reflex, and it can be a huge problem. And this is the big miss where I see patients getting hurt, because it's often not that first bolus that's really the problem. It's the second or third or fourth, and chasing the lactate with fluids on the theory that, I don't know, the fluids dilute the lactate somehow, which definitely makes no sense. Because you cannot forget that even philosophically, giving fluids will only decrease the lactate if the underlying shock physiology is improved by volume administration. And in a lot of shock physiologies, it may not be. And, in general in medicine, if something didn't work the first time, you should not then do more of the same, you should reassess. So I would like to propose what I call the lactobolus reflex alternative, and it is in 3 steps. 1, are you fully addressing shock precipitants, right? If you believe that your patient is in septic shock, okay, you're giving fluids, but nothing's getting better. Maybe you notice that they have, urosepsis, but you failed to notice they have a big obstructing kidney stone. Maybe you failed to notice that their previous cultures were resistant to everything. So are you fully addressing the shock precipitants? 2, are you correctly identifying the shock etiology in the first place? Go back to the drawing board. Is it actually septic shock? Was it actually cardiogenic? Do they actually have a massive PE? Were you correct in what you thought was going on in the first place? And then 3, is there an additional shock etiology developing? This happens all the time. It follows what I like to call Murphy's Law of critical care. The more that has gone wrong, the more that will go wrong. Because in sick patients, they develop complications, either from us, like let's say that your patient really was in septic shock, but then you put in a central line, drop a lung, and now they're in shock because they have a tension pneumothorax, or maybe they really were in septic shock, but after 4 liters of fluid, now they have a significant cardiogenic component. So is there an additional shock etiology developing, even if you were right about the initial thought on the shock etiology? There's no obligation for patients to stick to one problem, unfortunately. Okay. So if the answer is not simply fluids, and more fluids, this now brings us to the question of fluids versus pressors. So the first thing that I would like to point out here is that incentive structures that we are faced with in the hospital clearly encourage more fluids over giving vasopressors. 1, you don't have to put in a central line. I mean, you actually don't anyways. There's abundant evidence that it's totally fine to give peripheral pressors for some period of time through a good IV. But inevitably, somebody is going to get their hair on fire if you try and give peripheral norepi for too long, so it feels like somebody's pushing you to do it. 2, you don't have to call the ICU, right? The minute you pull the trigger on pressors, this now means an ICU admission. And, I don't appreciate, extra admissions any more than the next person. But more importantly, we all are trying to be thoughtful about conserving ICU beds for the patients who really need them. And so that thought process, I don't want to have to pull that ICU trigger, whether it's from the ED or the floor, can be very powerful. And last, you don't get angry emails from administrators for not giving enough fluid and therefore not meeting your sepsis metrics, which I tend to ignore, but nevertheless, we still get graded on it. What I would like to point out about these incentive structures, none of them have anything to do with physiology or actually what's best for the patient. They have everything to do with hospital structures. And they're not insignificant, you know? I mean, like, these incentive structures within the hospital are there and they're something that you have to deal with. So I can't say just ignore them, but I would say that we should recognize why we're doing what we're doing and balance that against the actual physiology and what's best for the patient in front of us. Because the thing, especially about septic shock, to keep in mind is that septic shock is at its heart not hypovolemic shock, it's distributive shock. And once you start thinking about that, it becomes important to recall one of the core principles of circulatory physiology, which is this: volume only counts if it's pressurized. You can have as much volume sitting around in the vasculature as you want to, but until that volume becomes pressurized, it is useless to you. And so pressurizing that volume in sepsis may in fact be more significant than giving additional volume. It's basically pressurizing the volume gets you more bang for the buck and allows you to actually use that volume. So this was a study that came out in American Journal of Respiratory and Critical Care Medicine back in 2019. And it looked at the effects of very early start of norepinephrine in patients with septic shock. And what they did was a prospective observational propensity match study of 160 some patients with septic shock. They did a very early vasopressor group where norepi was initiated within 1 hour of an initial fluid bolus. And this is much earlier than I was taught was safe, right? You're always like, we don't want to start norepi and then not give them enough fluids. And that's not unreasonable, but these guys looked at this. The very early norepi group started within an hour of that initial bolus. And what they actually found was this: the very early vasopressors group was associated with decreased net fluid balance and, much more importantly, decreased 28-day mortality with a hazard ratio of 0.31 and no increased evidence of acute renal failure. So this at least provides us some evidence that from a physiologic and patient care standpoint, it doesn't actually seem to be hurting patients to start very early norepi. Now, are you going to want to be thoughtful about this? Yes. Like, are you going to want to sit there and start at 0.05, then escalate to 0.1, and then be on 1 of norepi without giving additional fluids? Probably not. So if you're going to use this, stick it on, tell the nurse to titrate up to 1 million if they feel like it, and then ignore the patient, that's probably not the right answer, obviously. But there is at least some evidence here that just starting the pressors very early certainly doesn't seem to be harming people and may help them. This one, I think, is maybe the most relevant. So this was the Sensor trial, came out also in 2019. And this was actually a randomized controlled trial of 300 some patients with septic shock. And what they did was this. Patients, again, they were randomized to early low-dose norepi at a fixed rate versus placebo. And I think this fixed rate is a really important thing because the nurse can't titrate it. So it's not like you're going to find yourself in this situation of escalating and ignoring the patient, because if the nurses are up titrating the vasopressors, the really good nurses, they'll call you and be like, hey, we were on 0.1 of norepi, now we're on 0.6, something's wrong. But if you have an unexperienced nurse, they might do that. And the next thing you know, you're on a really high dose and you're not at the bedside trying to figure out what's going on. So in this study, patients were randomized to early low dose norepi at a fixed rate. And what they found was this. They didn't find any significant differences in 28-day mortality. The mortality in the early norepi group was 16% and placebo group 22%, but they did not have enough power to see if that was significant. But what was significant in this study was that the early norepi group was associated with more rapid control of shock and decreased incidence of pulmonary edema. And what I think is probably happening here is simply that you're addressing the stressed versus unstressed volume. In sepsis patients, you're giving them that little bit of vasoconstriction to pressurize some of the volume that you already have, and more importantly, it makes the volume that you're giving count more. Because if you're giving a whole bunch of volume to a patient who's really vasodilated and you give them, 500 cc's and 250 of that cc's is simply used getting you to a point that now it's stressed volume, you've wasted that amount of fluid. So giving that early, low-dose norepi to compensate for the distributive aspect, make the fluids you give later count more. So bottom line, fluids are complicated. And I think recognizing that and simply realizing that a one-size-fits-all solution is just not going to work with patients who are in septic shock or really fluid administration for any patients. Now, what I wish I could tell you is that I know the right approach to fluid resuscitation and I shall reveal it to you right now, and unfortunately I don't. Instead, what I would say is we're just trying to look for a reasonable approach to fluid resuscitation. For me, what that reasonable approach is optimizing volume status is one component of an individualized, iterative approach to restoring tissue perfusion. Because in septic patients, we don't have clear evidence that if the patient's truly septic, 30 cc's per kilo is necessarily clearly harming them, but we also don't have evidence that it's helping them, and we certainly don't have evidence that that's the right number of fluid to give somebody. So, to me, what is a reasonable approach? This is my approach at the moment, before more evidence comes out, to fluid resuscitation in sepsis. 1. What's my diagnostic certainty? How sure am I that this is actually septic shock as opposed to some other kinds of shock? Because sometimes initially it's just unclear. Am I certain that it's septic shock, or do I have reservations and I think something else, it's possible, might be going on? 2. Do I think that, yes, it's septic shock, but this patient has a reason to be additionally hypovolemic? So, if somebody has pneumonia, not so much. If somebody, on the other hand, is septic from their C. diff and is having massive diarrhea and volume loss, or let's say maybe my uroseptic patient has bad dementia and they've been at a nursing home and nobody's been giving them enough water and they haven't been able to drink and they're just really primarily hypovolemic. So if I have a patient who is also hypovolemic on top of whatever sepsis is going on, I'm more likely to give them a lot more fluid. Therapeutic window. So this makes a difference in terms of, am I giving them a bunch of fluid all in one go, or am I kind of aliquoting it? So different patients probably have different therapeutic windows. If I have a young, healthy person with a normal heart and normal kidneys, and, I think they're clearly in septic shock, I might give them a couple liters all at once right off the bat. If I have a patient with a renal failure, I might end up needing to give them the same amount of fluid, but I'm not going to do it all in one go. Or especially if I have a patient with heart failure, and I think this becomes really important. Because just because some patients baseline have heart failure doesn't mean you shouldn't give them fluids if they're in septic shock. You should. Where you are on the Starling curve is unrelated to the slope of the Starling curve. Often those patients do need a decent amount of fluids, but again, their therapeutic window is probably narrower than that young healthy person, so I might end up giving them the same amount, but I'm not going to do it all in one go. I'm going to give some fluids, reassess. Give some fluids, reassess. The next question I ask is fluid tolerance. So in terms of fluid tolerance, this is the question: will I harm my patient by giving fluids? What are the chances that they're going to get pulmonary edema? What are the chances that they're going to get sort of abdominal, intestinal, renal congestion? Do they have room for that? Also, in a bigger picture way, okay, is this a 90-year-old that has bad interstitial lung disease, and if I intubate them, this is going to be a disaster? Or is this a young, healthy patient where I have a lot of physiologic reserve and I can afford to make some mistakes in one direction or another? In addition, is this maybe a liver patient? A patient who doesn't have a lot of fluid tolerance because I can give them a large volume of fluid and it's all going to go straight to their lungs and their belly. So are fluids likely to harm my patient? What about fluid responsiveness? This is one of the very, very hardest things to assess. And you have to be quite good at ultrasound or have a SWAN in or have an intubated patient where you can really do some sophisticated metrics of this. And it can be very hard to assess fluid responsiveness. Really, will fluids help my patient in the ED and on the floor? So it's a question I ask myself, but in the context of all of these other questions. And if I have a patient where, let's say I have low diagnostic certainty, a low therapeutic window, I'm worried about their fluid tolerance and I don't know their fluid responsiveness, I'm more likely to start early pressors and then give them volume resuscitation on top of that. Because keep in mind, starting early pressors doesn't necessarily mean you stop volume resuscitating. What early pressors does for you buys you time to think, buys it time to do it carefully and thoughtfully. Now, recognizing that you need to go through this process and that it's complicated, you also need to recognize that your time is a zero-sum game. And I think we have enough evidence that 30 cc's per kilo is not necessarily the wrong number in many patients, means that for patients who are basically okay, they're relatively straightforward, they don't have a lot less going on, you don't necessarily need to spend a ton of time thinking too hard about giving them a couple liter fluid bolus. But in patients who are complicated, in patients you're not sure that something else may or may not be going on, or they're just not acting as you're supposed to, I really like the strategy of buying time with pressors, because that gives me the time and space to say, okay, I'm going to support the blood pressure, because sometimes, you're in there and the pressure's dropping and you feel the need to do something about it. No, I'm going to support the blood pressure, give myself time to really do a thoughtful and careful assessment of how much this fluid needs and how fast I'm going to give it. So that's fluids in sepsis. The first most important thing you got to understand is the difference between, is my patient developing shock and why is my patient developing shock? You got to separate the idea of sepsis from shock. Sepsis is one cause of shock, but just because your patient's looking shocky doesn't mean it's sepsis. The Surviving Sepsis campaign, I think it has done some really good stuff for us. What I think it's shown us is that if we sort of put in sufficient effort as a community, as a medical community here and worldwide, we have a really impressive ability to change our practices and improve. And I think the Surviving Sepsis has actually taught us that. What I think Surviving Sepsis doesn't do very well is thinking about, okay, individualizing patients. There is no one-size solution. And what we really need to start doing is figuring out how we can now change and improve in the direction of being more thoughtful about our individual patients. And I think it'll help us as more evidence comes out on this. This was a study that came out in Shock a year or two ago and is starting to explore things like clinical subphenotypes in sepsis and the implications of those subphenotypes for fluid status. Now, we're not there yet, but I think we should all pay very careful attention to this literature. When more of it comes out, I'll try and do an update. But in the meantime, thanks so much for listening.